3 centimeters, it is called a mass. If there is only one nodule, it is called a solitary pulmonary nodule. But many times you can have multiple nodules, so they are called as multiple nodules. Similarly, if a nodule is picked up for a scan which is done for some other reason, it is called as an incidental pulmonary nodule. If you do it for a screening purpose, then it's called a screen detected nodule. So there are so many terms which are there, but the most important thing we have to remember is the size. So now before we go on to the rest of the thing, we will go on a case-based discussion rather than a theoretical talk. So I've selected 4 cases. This is the first case, a 71-year-old lady who had come with cough and weight loss for 6 months. Cough was not resolving. A CT was done for evaluation of cough, and then we found a nodule in the right upper lobe. It's around 13 millimeters. Second case, a young lady who had come with hemoptysis, cough. CT showed only a nodule in the left lower lobe apical segment. There was no other abnormal, a 9 nodule in the left lower lobe. Another lady, 62-year-old lady, again she came with cough and a CT showed a nodule in the right upper lobe. This was a subsolid nodule. You can see some ground glass areas, some solid areas. One more lady, 65-year-old lady. This lady had multiple nodules. I only showed one nodule here. It's a periphyseal nodule which is indenting the fissure. So this is a 14 nodule. So I think if you see, keep on seeing CTs, you'll find a lot of nodules which are picked up when we do CT scans. Now, whenever we have a nodule, the first question we have to answer is, do we have to biopsy this nodule? That is the first thing we have to answer. So not every nodule needs to be biopsied. So the thing is, how to decide whether to do a biopsy or not. So what is the aim? Whenever we find a nodule, our aim is to pick up the diagnosis early. So be it lung cancer or be it infection, you want to pick it up early. At the same time, you do not want to overuse the investigation. So you do not want to biopsy every nodule. So you're putting them at the risk of complications after biopsy. So we have to weigh the benefits and risks of each of these. So how do? We look at the clinical or radiological picture. So what are the clinical features of a nodule being malignant is age, smoking status, past history of malignancy, and obviously presence of symptoms along with nodule. Radiological features are also very important. Larger the nodule, more is the chance that it will have a disease in it. Margins, again, very important. Spiculated margins or lobulated margins you want to sample. Location, upper lobes, again, they have been shown that can be malignant, and there are so many features which I cannot talk now, but these are the things which we have to consider. And also most important is the patient preference. You have to talk to the patient. What does he want? What is his thought process? And then you take a decision. So this is how we describe a nodule. Whenever we find a nodule, so you look at the location, the size, several radiological features like the margin, calcification, is it solid, subsolid or ground glass, cavitation, satellite lesions, and presence or absence of what we call as a CT bronchus. And this is a very important sign, because if you find an airway going to a nodule, then the chance of a bronchoscopic diagnosis is extremely high. So this is something which I will suggest that all the people who are looking at nodules have to look at this particular sign, CT bronchus sign. This is the third case. Again, similarly, if you describe the nodule, this is a subsolid nodule. It's a partly solid nodule present in the right upper lobe, ill-defined margins in 16 mm. Whenever we have a partly solid nodule, the chance of adenocarcinoma is extremely high. You have a lot of models, but none of them are valid in India, so we won't talk about these things. But what is important is we have international guidelines which we also follow. The golden thing is, if the nodule is above 8 mm, only then we should think of biopsy. If it's a small nodule below 8 mm, most of the times you would only want to repeat the scan and see. So that is a thing which we have to remember. Only 8 mm and above we want to sample. Now coming back to the index cases, which of these nodules would you want to sample? So the first case was a small nodule, looked benign, but here, though we didn't want to actually sample the patient asked for a biopsy because they were very worried that it could be malignancy. So that is how patient preferences come into the picture. Second case, she was having active hemoptysis, so we actually wanted to find out what is causing it, so we thought we should sample. Third, obviously, it's a subsolid nodule, very high chance of malignancy, so you have to biopsy this lesion. Fourth, again, multiple nodules, cough, fever, weight loss, the chance of some diagnosis being there is high, so again, you wanted to sample. For the sake of discussion, I only kept cases where we did a biopsy, but in reality, there are many nodules where you would just follow and do not do a biopsy. Once you choose to do a biopsy, now the two options are CT guided biopsy or a bronchoscopic biopsy. So these are the two things. CT graded biopsy has been there for a long time, decades, and which is what is followed across the country. So definitely it has a better diagnostic yield of up to 85 to 90% as compared to bronchoscopic biopsy where we have a yield of around 75 to 85%. But CT graded biopsy comes with certain complications like higher rate of pneumothorax and higher rate of bleeding. So here I would say the advantages of each of these. So bronchoscopic sampling, the benefits are that lesser complications, and even if at all the bleed happens, your bronchoscope is inside, so you can control the bleed better. The third advantage in India, especially, is the fact even Lokesh has shown nocardiosis, mucormycosis, so on and so forth. So a lot of infections can present as nodules. So when you do bronchoscopy, you can get good lavage fluid and you can use this for microbiological diagnosis. The fourth important thing is a simultaneous staging of the mediastinum can be done. If you find on rows at the same time that the nodule is malignant, you can do the mediastinal staging using linear rebus at the same time. You will decrease the number of times the procedure is done. And obviously, when you have a case where the nodule is central, where there is a lot of emphysema, where the chance of CT graded biopsy causing pneumothorax is high, bronchoscopy obviously will come to the rescue. But at the same time, I should say CT graded biopsy also has several benefits. One, it has a better diagnostic yield. Why it has a better diagnostic yield? Because the needle can bypass the normal anatomic structures, which is the bronchi, can puncture the lung and go wherever you want. Whereas in a bronchoscopy, you are bound by your bronchi. So only where the bronchus takes you, your accessories will go there. Second is tool-in lesion confirmation. So in a CT graded biopsy, the moment you put the needle, you do a CT, you confirm you're in the center and then do. This is called as a tool-in lesion. This is something which is there only in CBCT of the various bronchoscopic techniques. Other techniques do not have a real-time tool-in lesion confirmation. The other advantages are that obviously lesser cost and ease of access. So definitely in our country, CT graded biopsy and bronchoscopic biopsy both have a role. And slowly what is happening is where the centers have access to bronchoscopy, more and more cases are being done through bronchoscopy. But at the same time, if you have a subpleural lesion, we still do CT graded biopsy only. So we have to choose which is the correct thing for that particular patient. Now coming to last couple of minutes will be on the bronchoscopic biopsy, how it is changing. So before 2002, we did not have radial EBUS. Radial EBUS is a technique wherein you can see the peripheral nodule or a peripheral consolidation. So it's a small probe which rotates and you can see the structures around the probe. So before 2002, the diagnostic yield was very less, that is pre-radial EBUS, so it is very bad. So after radial EBUS has come, the yield has gone up to 60 to 70%. But with the newer technologies like navigation, cryobiopsies, cone beam CTs, and so on and so forth, the yield has gone up to 85%. Now you're also reaching 90% in some centers, which is as good as a CT graded biopsy. So you're able to increase the yield and keep the complications at a minimum. That is how bronchoscopy is beneficial if you have access to these technologies. So what are the new things which have happened in bronchoscopy is overcoming the disadvantages of the previous setups. So now you have several technologies which will help you reach the nodule. So more distal the nodule, the more difficult it is for us to reach. So you have several navigation technologies. In India, we have two, the lung point by Bronchus and synapse by Fuji. You have thin scopes. So Lokesh has spoken about the conventional scopes. You have 4 mm scopes, 3 mm scopes, which are therapeutic scopes. You can, using the scope, you can reach much distal into the airways. Then the latest thing is what we call as tunneling technology. The same way a radiologist will puncture the lung and go, the same way a pulmonologist can puncture through the bronchus, go into the parenchyma and reach the nodule. This is called as tunneling technologies. Similarly, the tool-in lesion. So I have shown you that when you do CT graded biopsy, you can see the needle exactly in the center. That's called tool-in lesion. Same thing now you can have with technologies like augmented fluoro and cone beam CT. These are, I'll just show one cases, that's all. So now coming back to the index cases. So once we decide to do a biopsy, so in these cases, if you see all of these cases were in the central 1/3, most of them. So all of these actually were chosen for bronchoscopic biopsy. But if the same lesion had been subpleural, we would have done a CT graded biopsy. Now, how do we go to these lesions? The second step is navigating to the nodule. This is very important. So second step is to navigate. As I've said, There are two ways. You can just see a CT, understand the anatomy and go, or you can use a software called as a navigational bronchoscopy. So this is a navigational bronchoscopy lung point, which is there in India for the last 5 years, I would say. More and more centers are getting access to this platform. It's all AI based, so you just have to mark the nodule the way we have done here, and the computer itself will give us the path. So in this case, the first case, you can see the path is going into the right main bronchus, right upper lobe bronchus, anterior segment, anterior subsegment. In that, here it is there adjacent to the lesion. So you exactly know where you have to go. So this is for the second case, which is there in the left lower lobe. It is very small nodule, so if you will get lost if you don't have a navigational platform. So here also, if you can see, the software will give us the path. It's going into the left lower lobe, apical. Again, it's going deeper into the subsegment, so you can memorize the path and then go and reach there. Similarly, this is for the third case again. So whenever we have a lesion which is less than 2 centimeters, we would take the help of a navigational software. If you don't have the software, if you have a good quality CT, you can still do manual mapping and you can reach the nodule. So it is not that you have to have a navigational software. Obviously, you combine it with a thin scope, your normal scopes will not go till there. And once you navigate to the lesion, the third thing is you have to see the lesion. So this is one image which shows a radiolibus, the first one. Second is fluoroscopy, which Dr. Lokesh also has shown you. Third and fourth are augmented fluoroscopy. This is what I will talk about. So radiolibus is something which is now almost every center having a good IP suite has access to radiolibus. So Vijayawada also has a lot of radiolibuses with them. It is the backbone for evaluating a nodule through bronchoscopy. So once you reach the site, this is the radiolibus probe. You switch on the probe, and then this is the nodule which you are seeing there. So, so these are all the radiolibus images for each of these cases. So once you have a radiolibus image, your diagnostic confidence goes up. So you can have different types of radiolibus images, which again I will not talk about because the talk is only to give an overview of what is there. Fluoroscopy. So if you carefully see the image which Lokesh has shown you, the lesion was large. So you could see on a conventional fluoro. If you see this case, the lesion is so small that you can't see it on a fluoroscopy. So then you use what is called as augmented fluoro. Means a lesion which is otherwise not seen on fluoro will be seen on a fluoro. That is called as augmented fluoro. So once you have an augmented fluoro, you can actually see that you are actually going there. You can see these two pictures. The bronchoscope is directly going to the lesion. Here you can see the radiolibus probe is directly going to the lesion. So this is called as a two-dimensional tool-in lesion. This is for the second case. You can see the apical nodule. The red dots are the path, and once you put the radiolibus and the cryoprobe, you can see exactly you're in the nodule. So this is called as a tool-in lesion confirmation. This is for the third case. Again, you can see right upper lobe, augmented fluoro, and the bronchoscope is directly going, and you can see the probe exactly there. So these are all possible for even small lesions. For case 4 again, this is a 14 mm nodule. Apical segment, the nodule is exactly where the hilum is there. So you can't see it on a fluoro. Whereas on augmented fluoro, you can see it and you can see the radiolibus going there. This I will skip for the sake of time. The other thing I would say is now coming to cone beam CT. This is the newest thing. Just like a radiologist does CT during the procedure, the bronchoscopist also has ability to do a CT spin while he does the procedure. So this is the CT spin which is being done once the bronchoscope is inside, and then you can actually confirm the tool in all three planes. This is called as a three-dimensional tool-in lesion. So if with this you will be very confident that you are exactly at the place where you want to be. This is for the third case. You can see the ground glass opacity. The cryoprobe is exactly at the ground glass opacity, and then you take a biopsy. Last thing is sampling. Again, for the sake of time, I'll just tell that you have two ways. One is the forceps and second is the cryo. So more often than not, we use cryobiopsy over forceps biopsy because we get bigger tissues. Last thing is to analyze the sample. Having a good pathologist will make a lot of difference. If he can be there with us while we're doing the procedure, we will know on the table itself what the diagnosis is. So with this, I will end my talk and then come to the diagnosis. So the first case actually turned out to be a carcinoid, second turned out to be TB, third turned out to be adenocarcinoma, and fourth turned out to be nocardiosis. So exactly the same way Dr. Lokesh has shown that consolidations can be because of several reasons. Nodules can be because of multitude causes. They can be neoplastic causes, benign tumors, infections, and it is very important to identify them early and correctly so that you can give the correct treatment to the patient. So lung nodules, yes, they're increasingly being detected. A lot of diseases can cause them. It is important to evaluate them timely so that you pick up early stage lung cancers and then give a curative intent resection. A lot of new technologies have come in wherein you can increase the diagnostic yield and decrease the complications. With this, I'm very happy to say that we've recently started a lung nodule clinic in our center, and we would invite you all for our lung nodule summit. So whatever we have discussed in the last 20 minutes, we will be discussing over 2 days. It's a large, vast area, and all of those who are interested to learn about lung nodules, more than happy to welcome you in Hyderabad. Thank you so much.
That's a wonderful talk, sir. I know you just spoke in 20 minutes, like you said, but it's a vast topic and it's also evolving in India. And I know you're one of the first one to do with the cone beam CT and also maybe in future robotic bronchoscopy as well. But so thank you very much once again for a wonderful talk. So any comments, any questions you can. And also, sir is doing next week only. Next Saturday, Sunday is doing 2 days conference. So we all will be there. So thank you. Yeah.
Okay, Dr. Lokesh, if there are no questions, I will log off. Is it okay?
Nagarjuna, I have a question for you.
Yes, sir.
Missed you here. Hi, Raja here.
Rajesh sir, how are you, sir?
I'm good. So I just said I missed you. Lovely talk as always. I was going to ask you a more sort of a philosophical question. Do you think with the use of sampling, the various techniques of sampling peripheral pulmonary nodules that you've depicted, do you think a true cut biopsy, the conventional transthoracic true cut biopsy is a thing of the past now? Or do you think there's still a place for this investigation?
So definitely both have their place. I will not tell that bronchoscopy is going to replace CT guided biopsy at all. So in our center also, even though we have access to every gadget, we still do a lot of CT guided biopsies. So how do we choose which patient to go for which procedure? So one is the location. If it is touching the pleura or immediately subpleural, we would still go for a CT guided biopsy. Second, very important thing is the presence of a CT bronchus sign. So if a nodule has a CT bronchus sign, then our diagnostic yield crosses 80%. So these nodules are those nodules which we would give them an option that we can do the procedure at the same diagnostic yield, but at a much lesser complication rate. So these are the two important radiological predictors of how to determine which technique to do. But not talking about the global scenario, sir, there are several countries where I have spoken to where they don't do CT grade biopsy, they only do bronchoscopic biopsy. So it all depends upon where you are working, what is your skill set, and what are the gadgets which are there at your place. In India, CT guided biopsy would be there for several decades from now, and it's going to be there. It is just that in a subset of them, you would slowly start doing bronchoscopic procedures for the advantages which I have already spoken, sir.
Thanks, Nagarjuna. Thank you very much and look forward to seeing you soon.
Sure, sir.
Thank you, sir, once again. Now it's like a 2020 match. We are having a lot of talks from morning. We're almost, I think we finished 15 hours now. Last 5 hours left. So there you have stalwarts like Deepak Talwar sir and Rajadhar sir who will be eating last 5 hours. So let's wait for the show. So in between lunch and us, we have one panel discussion now. So let us finish and go for lunch. Excuse me if you're hungry, but if you finish it, then we can be at peace so that they have to leave by 3 o'clock, some of them. So that's the reason we're just continuing. Thank you.